Okay, now we're at Module 2. We'll talk about bipolar affective disorder, and then I think we'll have time to talk about ADHD and a few words about stimulants. So, having a single manic episode is diagnostic for bipolar disease. And if you've never seen a manic episode, it has elements of paranoid schizophrenia. There's pressured speech. They're physically hyperactive. They get agitated. They don't sleep. They spend a lot of money. They can be hypersexual, hyperconfident. And it's definitely bipolar 1 is often psychotic. A few years ago, Charlie Sheen was on the news all the time and letting himself be recorded, and I kept hearing psychiatrists say things about how they could never diagnose a patient who wasn't their patient, but that he had a lot of the elements that one would expect to see in bipolar mania. Okay, so you have either the mania or hypomania, which is more on the next slide. There's a whole range of how bad the mania is, how bad the depression is, how often it occurs. Every once in a while there can be a mixed episode where you have depression and mania sort of together. That's a particular suicide risk. Bipolar patients are already at a very high risk of suicide. We'll talk about that more. Okay, so hypomania is milder than, and it definitely won't be psychotic. So it's very different than bipolar 1 mania. They can keep working, they're not hospitalized, and for both types, the duration varies. A single episode might last days, up to a year seems to be months. They can have repeated episodes of mania without depression, so there's sort of every imaginable pattern of these two different moods. The average, so the mania might last a few months, that's an average, and they have an average of 4 episodes in the first 10 years. So that's why somebody might get to be in middle age without having been diagnosed if they haven't had that many manic episodes. I'm going to come back and talk about this book in a minute. There was the most space for my photo right there. Okay, so how prevalent is it? We know now that there's a spectrum. Bipolar 1 is full mania or these mixed episodes. Bipolar 2, much more frequent. So this is the hypomania that's not psychotic. They won't have the mixed episode, but even bipolar 1 is 1.2% of the population. That's really pretty common. There are a lot of people who are dealing with bipolar 1. And that's why I want to kind of introduce this book. Usually I would bring the book with me to class and I would show you. Last year, when I fished out this book to take to class, I got so interested I read the whole thing again. It's actually a very fast read. It's beautifully written. It was a bestseller because she's such a great writer. So she was a psychologist, a PhD psychologist, clinical psychologist, practicing when she became symptomatic in her, I think she maybe wasn't diagnosed till her late 20s. Anyway, it's a wonderful description of what it's like, what it feels like, what the psychosis felt like, and there's a lot of information about lithium and how important it is, which I'll come back to. But it's not a difficult read. It's definitely worth reading. She began here at UCLA, so the book has a lot about UCLA in it because she was a graduate student here and she practiced here before she moved to the East Coast. Didn't I cover? So sometimes it'll be rapid cycling, and these days it may well be managed in primary care. That didn't used to happen, but it does now. And I've already mentioned that a new depression onset should always include consideration of bipolar. Okay, drug classes. Mood stabilizers are the most important. We're going to also talk about antipsychotics and antidepressants. These patients may also take benzodiazepines for sedation. And this is one of those conditions where compliance is always an ongoing concern, which, by the way, Jameson talks about in her book, about how she struggled with compliance, and she talks very frankly about it. Okay, so we'll start with the lithium, which was the original mood stabilizer. I did some checking. We still don't know exactly how it works. Back in the early to mid 2000s, people had pretty much stopped. Prescribers had stopped using lithium, and instead they were giving valproic acid, which we'll talk about next, because it doesn't have most of lithium's toxicity issues. So they stopped using it, and then a big study came out that showed that suicide risk was quite a bit less with lithium. So suddenly people had to prescribe lithium again, and I remember reading a lot of psych residents had never used it, so they had to have all these teaching and in-services to teach everybody how to prescribe lithium. For its pharmacology, it's like the antidepressants in that there's a time lag. Okay, I think it's a little bit less than the time lag for antidepressants. I think sometimes it works within a week, but it may be a couple of weeks. And so if they are in a psychotic, if they're in the middle of a psychotic manic episode, they may need to be given an antipsychotic or a sedative benzodiazepine to control the psychosis until the lithium kicks in. Okay, so back before this suicide study came out, atypical antipsychotics had become first line for acute mania. Lithium, I've already talked about. It has a narrow therapeutic window. I have another slide on that. And monitoring blood levels is critical. It has a very short half-life, although there are now extended release formulations. Some patients, for this and for ADHD drugs, I guess the same thing is true for diabetics. Sometimes when you need better, tighter plasma level control, you dose more frequently to get a smoother level. So with the original formulations, soluble formulations of lithium, they needed to be taking it 2 to 4 times a day. And so you can imagine somebody who doesn't want to take a drug and they have to take it not just once a day, but up to 2 or 4 times daily. You can see where the compliance issues come from. And I just mentioned in the last module how sometimes these days lithium is added on for unipolar depression. That's pretty new. Okay, so this is the slide about the toxicity. So lithium toxicity is affected by the sodium levels. And if they're dehydrated, if they get the flu, if they're traveling, they can have higher plasma levels and become toxic. And you'll see why that's so important if we look at the plasma levels. So mild lithium toxicity occurs at less than 1.5 milliequivalents per liter. And so notice here, the therapeutic dose is 0.6 to 1.2 milliequivalents per liter. So you're already really close to the top of the therapeutic range when you start having symptoms. And in fact, in the book, Jameson talks about how she had to live with a tremor, and she was uncoordinated, she couldn't ride horses, but that was part of what she had to do to keep her lithium levels in an effective range for her. She mostly talked about uncoordination. She mostly talked about bad handwriting. They may also have a slurred speech and this hand tremor at lower levels, at therapeutic levels. And then as the plasma levels go up from there, you begin to get central effects, EKG changes. Lithium is an an ion. It's really small. It's going to go everywhere in the body. I added a car battery just to remind us that, you know, lithium's not even really a drug in the usual sense of the word. It's an element, and it's used in a lot of different ways. But they become the toxicity is really central. Even though they may have EKG changes, they're sedated, they're uncoordinated, they can't walk, they have gait troubles, they might have seizures. So the toxicity is mostly CNS toxicity. Before I leave lithium, yeah, this was in the paper last year. She came, so it was Kay Redfield Jameson. She's currently a professor at Johns Hopkins. She came to, so one of the things that she does is she gives talks to college students. And so this article was earlier this year. She came to Caltech and she gave a talk. She talked about how lithium should really be the treatment of choice. It improves decision making, but she feels like it's overlooked because of the negative stigma it has as an older drug. She feels like that the newer medicines are more expensive, and drug companies are complicit in trying to move away from lithium. She also, and remember, she was a practicing clinical psychologist. She attempted suicide one time, and she attempted with lithium because she knew how toxic it was. And she took the lithium together with an antiemetic to keep from vomiting the pills because she was determined. And she was in and out of a coma for several days, and she nearly died. And so, recovering from that suicide attempt, she vowed to do these college talks and to speak and try to teach people about lithium. So, very interesting drug. Other drugs that you will see. So, I already mentioned valproic acid at one point was first line. For some patients, it may still be first line. It's definitely preferred in that acute manic stage when they may be psychotic and lithium hasn't kicked in. It may work in patients who don't respond well to lithium. It's safer, you can work with the dose more. And it may be combined with lithium if monotherapy fails. And then, and this has been true, so the valproic acid and the atypical antipsychotics have been used for a long time. So it's been known for a long time that they had mood stabilizing effects. So in addition to their anticonvulsant effects and their antipsychotic effects, they are mood stabilizers in and of themselves. We're going to cover antipsychotics in the next block module. And keep in mind that bipolar patients may definitely be on just an antidepressant. But they need to stay on the mood stabilizer to keep from going back into a manic episode. So bupropion, venlafaxine, remember that was an SNRI, tricyclics, and some of the newer agents we talked about already, they may precipitate a manic episode. Those are not good choices for bipolar patients. Okay, a little bit about stimulants in general before we move into the ADHD drugs. The chemical name for most stimulants, at least for caffeine, which is the one we talk about first, is methylxanthines. These are the over-the-counter stimulants. So theobromine is in chocolate. Still not clear exactly how they work, but and here I'm mostly focusing on caffeine. So here's the structure of caffeine. Caffeine has non-specific stimulant effects, but it's very well demonstrated that people are more alert, that there's vasoconstriction of the cerebral blood vessels. That's why related drugs are used in migraine. They stimulate the heart, they stimulate diuresis, They actually stimulate athletic performance, better athletic performance because of this increased alertness. But there are adverse effects, which most people are aware of. Withdrawal, a headache, a caffeine headache in the afternoon is the most common withdrawal syndrome. If somebody says they have a headache in the afternoon, this still happens to me all the time. And I say, well, do you usually have a Diet Coke in the afternoon? And oh, yeah. So sometimes people forget to have their afternoon caffeine. The excessive stimulation, so you can feel it in heart rate and jitteriness. I won't eat them anymore, but I know what this feels like, and you can test it out. If you eat those coffee beans that are coated in chocolate, that's a massive caffeine dose. And like I say, I can't eat them. I don't know how anybody could do that routinely, because I immediately feel very, very jittery. And it can also cause GI irritation. So caffeine has real demonstrated pharmacology in terms of stimulant effects. I think they took it out of the new Laney book, but I left this in just because it is interesting and it is real. It is true that dogs are not supposed to have chocolate, and the reason why is because they are slow metabolizers of caffeine and theobromine, and it's especially worse with dark chocolate. And it can be fatal, but it has to be enough of a dose to be fatal. So a 10-pound dog, that's a small dog. 9 ounces of milk chocolate. Milk chocolate is that's quite a bit. But only 3 ounces of bittersweet chocolate. Only 1 ounce of the unsweetened one. So a little dog doesn't have to eat a lot of dark chocolate. It's definitely dose related, but a big dog can get away with getting up on the counter once in a while. All right. So we'll go to amphetamines and ADHD. So ADHD is characterized by excessive motor activity, but honestly, it's the attention span and the difficulty controlling impulses that causes more trouble for people with ADHD. And in childhood, you have potentially a lot of really serious sort of social, psychological effects, family effects. They may not do well in school. They don't feel good about themselves. They may think of themselves as dumb. They may be rejected. And the parent-child relationship is definitely affected. In the last, I would say even 20 years, there's been heightened awareness. They used to think it was 3 to 5%. Now it's generally thought to be a lot more. Something like 1 in 10 12-year-old boys will be taking a stimulant. And there is a trend for treatment into adulthood, where up to 65% may still be affected. We'll talk about that a little bit more later. But some will outgrow it. And sometimes the adults who have it, they have all kinds of social employment difficulties that they're not really aware what the problem is. So there may be new diagnosis and new treatment in adults. Okay, how do amphetamines work? So and this it's a reminder of antidepressants. They block those reuptake proteins that increase the amount of catecholamine in the synapse, but they also cause the release of all of the catecholamines, which means norepinephrine, serotonin, and dopamine. And so amphetamines are sort of like a blast of catecholamines. So way different pharmacodynamics. There's a little bit of overlap with antidepressants, but much more of a blast effect in terms of synapse. So they do all the things that you would expect from a drug that a lot of school children are taking. They can stay on task better. They're more alert. They have fewer negative, impulsive behaviors. I just kind of lumped most of the drugs together here. They're chemically different, but they're also methylphenidate doesn't really sound like an amphetamine, but it is. It has the same actions. And Adderall is the most common amphetamine that you'll see today, although there are others. So here's an enantiomeric purification, trying to get more potency. They do have long duration formulations so that hopefully people can be dosed once a day, especially kids who used to have to go to the nurse's office to take drugs. It's another reason for making them feel bad about themselves for standing out. But on the other hand, if they need tighter control, they may need to take more than once a day. So the long formulations are not good for everybody. And there's even a transdermal patch, but with the transdermal patch, you're also going to get much more unpredictable plasma levels. So that's not going to be probably for more severe patients. There was a faculty member here who worked in the ADHD clinic at Kaiser, and she said for really severe kids, they used to actually give some of them methamphetamine, which is just an interesting fact. Okay, how does it work? Well, it seems paradoxical, but the way to think about it is that amphetamines stimulate their ability to pay attention. There's been thinking that this was in the thalamic system, which when we talked in the very beginning in the CNS, I talked about the thalamus being an important relay center, an important way station for sustaining alertness from the reticular activating system. So it makes a lot of sense, but there's newer studies showing frontal cortex effect. I keep checking. I don't think they've really nailed down exactly where in the brain stimulants are working, but there are definitely changes in the prefrontal cortex. Now that makes sense. Prefrontal cortex drives impulsive behaviors. So it does make sense that they would have a lot of activity there. So this is an illustration of, so instead of just serotonin or norepinephrine or sometimes both, here we have dopamine, norepinephrine, amphetamine. So we have all of the catecholamines being released and uptake being blocked. So tons more neurotransmitter in the synapse with amphetamines. Okay, adverse effects. Not surprisingly, trouble sleeping. They may need to take it in the morning and not take it again. Amphetamines were originally prescribed as appetite suppressants. They were given for weight loss back in the 60s, and they were given to truck drivers to keep them awake. That's why, and then it quickly became clear that they were very addicting. There was a lot of abuse potential, a lot of severe adverse effects, so they really clamped down on all of the other indications for amphetamine. So in the beginning, it wasn't clear how dangerous they were. It's a significant cardiac stimulant, and so for a while there was a black box warning. It may still be there for adults, and that was because there were deaths because people had MIs, they had various hypertension, arrhythmias, and they were on stimulants. So for a while there was a huge fear that this was a risk for kids, but that's since been removed. I have a slide that says that later. Tolerance is really important with amphetamine. So tolerance means that when you take more of it, when you keep taking a drug, you have to take more to get the same effect. That's what tolerance, simple, and we'll talk about it again with drugs of abuse. If you have to take more to get the same effect, happens with opioids. It happens with some drugs that are not drugs of abuse. But amphetamines, and there's even something called tachyphylaxis, which I had to learn about in my pharmacology graduate courses, which is an especially rapid tolerance, and that happens with amphetamines. So they used to do drug holidays for children to try to get their doses back down. There seems to be less emphasis on that in terms of clinical management now, because then they have all kinds of trouble at home with their parents and with families. So, families have to decide together how to manage the side effects of stimulants. So these are Schedule II drugs. This physical dependence addiction potential is a huge deal, which is why it's so worrisome that so many college students take it, which we'll come back to. Overdose with stimulants always leads to a very severe psychosis. That's been well documented. Oh, here's another one. Somebody mentioned this to me a few years back. It's a newer stimulant. It is given as an inactive prodrug. It's converted, it's metabolized in the body to dextroamphetamine. And it's also racemically purified, which means that it's more potent. It can be given in a smaller dose. They were hoping when they developed it that it would reduce abuse and be more useful in adults. But I checked this is within the last year. There's no evidence that it's superior to the other amphetamines so far. Okay, so what are these issues? So, and this is an old study, but it just makes such an important point. Ritalin works well enough to erase the diagnosis. So after talking about drugs, patients are refractory to antidepressants. Patients are refractory to lithium and other drugs. But stimulants in ADHD almost always work, the vast majority of the time. And they don't just work a little bit, they make the child essentially normal. And this particular study, which is, again, it's an old study, suggested that maybe kids were actually under-medicated. So there's, continues to be a certain amount of controversy. Are kids underdiagnosed? Are they overtreated? But there's much more acceptance in parent communities and in the field for support for parents who decide to medicate their children appropriately. There's just a very long record of safety and efficacy. Teachers, not surprisingly, are huge fans. They can see the difference that it makes in kids. So back to this treatment in adulthood. Up to 90% of those may be untreated, previously unrecognized. So you'll see more and more new diagnoses. But a third of adults don't respond. So kids respond better to stimulants. Adults will sometimes be prescribed, and sometimes they work, but sometimes they don't tolerate the side effects, and sometimes they just don't respond. So there are non-stimulant alternatives, and I think I have a different slide for each of these. I just wanted to mention a few issues. So this cardiovascular event, there used to be a black box. They reversed that in 2011. But this potential for misuse is a really big issue. I didn't used to have this on my slide, but we would talk about it when the BS students do case studies. A bunch of them did, had friends who took stimulants for ADHD. A lot of them have new diagnoses. But this paper is from 2014, but it suggests 5 to 10, this is multiple studies because this is a review, 5 to 10% of high school students, 5 to 35% of college students may use it as a study aid. And we talked about in class how, well, why don't the colleges do something? I see online that a lot of colleges seem to be having sessions and information that's available to discourage misuse of stimulants, but it's interesting because they're also very dangerous drugs. I teach every undergraduate I can ever talk to. Don't underestimate the seriousness of this, but on the other hand, if they're used very rarely and used in low doses, you're not going to get tolerance, you're not going to get addiction, you're not going to get continued misuse. I think the potential for misuse is really people mostly people who are prescribed. It's prescribed to them themselves, and they take it every day. They become tolerant. Okay, so a little bit more about these non-stimulants. So alternatives to the stimulants. Atomoxetine or Strattera is one. It's a norepinephrine reuptake inhibitor. Okay, it has essentially the same effect as an antidepressant, but as far as I know, it's not really used to treat depression. It is used as a non-stimulant treatment of ADHD for people who don't tolerate the stimulants. There's no abuse potential. The stimulants clearly work better. The data shows that they work better, but they're an option. And they do tend to cause suicidal thinking in children, which some antidepressants do the same thing. This is much newer, these alpha-2 adrenergic agonists. This is within, I'd say, the last 3 or 4 years. Guanfacine, this is a really old drug, and clonidine. Recently approved. Both are originally antihypertensives. Clonidine is still one that's used. It's like a fifth choice drug, but it's still used sometimes. They're not controlled, no abuse potential. They're also not as effective as the stimulants, so they may be preferred in some populations.